Hi, everyone. Thank you for being with us here today. I have to say I'm a little bit under the weather. I've been a little sick for the last couple of days, so apologize my voice. And if I need to take some breaks, getting some water here and then, that's why. So today we're going to dive into the denture conversions, but it's more of an overview. And this is a very basic information. For some, it might be too basic. If you're not in these cases, it's probably you already know this stuff, but for those that want to dial and start doing this type of cases, this will be a good place to start. So the all for Pro Watch all the next different doctors or labs or oh, the questions are showing. Friend, do you see the questions on the screen?
Yes, the first question has been launched and it'll just be, not even a minute and it'll come down.
But okay, so you won't interfere with the presentation?
Not at all.
Oh, okay, because it showed here. So okay, so different doctors call it different things, but it's basically the rehabilitation of the dental patient or patients with terminal dentition with 4 or more implants. And the technique was designed. I'm sorry, Fran, the question's on my screen. I cannot move to the next slide. Here we go. It disappeared. I can still do it. Oh, okay, here we go. The O4 was created as a procedure that it would be graftless, so doctors don't need to add bone in order to move ahead with the placing implants and a temporary restoration. It was designed also for at least 4 implants where the posterior implants are tilted. So there's more of a better AP spread, and we can actually load or offer the patient with a restoration with more teeth, like 12 teeth at least. And because we are doing the middle load the same day, we are actually helping the osseous integration of those implants. So for the full arch workflow, I tend to divide in different stages. And the first one will be the denture design. Then is the actual conversion that happens at the end of the surgery, and then the final restoration. We're not going to dig in final restorations at all, but we do have to acknowledge that the final restoration is crucial to know what your final is going to be for your denture design. Because if your final will be a PMMA with a titanium bar, you need at least 15 millimeters of restorative space. If it's zirconia, nowadays there's a lot of different ways of doing the zirconia. You can have a bar or not, but with zirconia, you can get rid of away with less space. So it's crucial to know what your final is going to be. Both of my cases are titanium bar with PMMAs, and there's a lot of controversy if that should be offered as a final or not. That is what my doctors do. So I already know that I need to work with that 14 to 15 millimeters of space. So when I'm designing my denture, I need to acknowledge that. So the analog planning, and this is what every technician knows how to do, right? You get your impressions, you pour your models, and you articulate your models with the visualization that the doctor sends you. And then, of course, hopefully you get photos, and photos should include the whole face, because sometimes, if you only get the smile, photo is not enough for your planning, at least accurate. Sometimes the midline do not align with the papilla or the lips or the nose, and the full photos are essential for this type of cases. And you use the basic knowledge of setting teeth. And again, consider the bone reduction for this type of cases. You have to have that space, so you have to reduce your stone cast in order to accommodate that specific thickness for your denture ahead. And then you design your case, you set your teeth, you add, festooning, wax, and then you process your denture. In the analog, no one is going to do in this case specifically. I did a bite just to help the doctor and me at the time of the pickup. But, the analog, you were not going to spend time designing or setting teeth on the lower for this type of cases. And that with the digital workflow now, or the digital planning is a lot easier to do that because it's very quick and simple. But back then, the analog planning, that would be it. We will create a bite and have our denture. I will polish the denture a little bit on the teeth side, not much on the acrylic or the intaglio. Actually, on the intaglio, I would add some sandblast. I would sandblast the base just to make sure that once we add the new acrylic at the day of the surgery, the conversion, the acrylic would hold properly. And then there are different ways to do the conversions, and I'm gonna go through those. But most of my cases are free-handed. That means that there's no surgical guide to follow. So besides the denture, we have to create also what's called a stent. And the stent is basically the duplicate of that denture. And that will do two things for us, or for the doctor or a surgeon as well. It will help us with the bone reduction, will help us with the bone reduction to make sure that we have enough restorative space for our restoration, and it will help us with the multi-unit selection to make sure that all the holes are coming in the right place on the lingual of the teeth. So again, because most of my cases are 15 is PMMA titanium bar at the end, I already know that is 15 millimeters, and that's what I mark on my guide. So when we are in surgery, we are sure that we follow the restorative space, and I'm not going to have any restrictions on the road. And then for the multi-unit selection, we want to make sure that all the implants, the screw axis is on the lingual of the teeth. So we open that lingual opening on the denture. And the analog way that I don't know what this is anymore because I do mostly digital now, but it was very tedious to do this stents. It's something that it stays in the mouth or is used at the day of the surgery for less than 5 minutes. And it still is not difficult to do, but it's very tedious to do. And you would have to grab duplication box and just do it just like you would do how you duplicate a denture. You just do alternate on one side, you bury your denture, alternate on the other side, you close it, and then you pour your acrylic and cook it. Now, what if you want to dive into intraoral scans, or your doctor starts sending you intraoral scans, and you have no clue how to get started? Because this is what happened to me, and this was exactly the first case that I received from a doctor, and I was completely analog at the time, and he sent me an email. Well, I send you some scans. The patient cannot take impressions, and we just have to do it digital, so figure it out. And at the time, I had no clue, and he sent me a bunch of scans, but I couldn't even open them because I didn't even have a proper software to see what was coming. So every time an intraoral scan comes, and normally it has photos attached, so this is actually the only thing I could see at the time. But when you have these, and to get started, and this is something that, I got information down the road with a couple of friends here and there and technicians, get yourself, go online and get Mesh Mixer. And with Mesh Mixer is free. It's a software that you can do a lot of things with, but at least if you have a doctor that sends you intraoral scans, you can open the scans and see if they're aligned in centric relation or not, and go from there. Of course, that if you are completely analog, you have no clue how to work with those scans, but at least you start getting to something. And for this, basically all you need is that software. You open your scans. If they're aligned, you can just, you can just print those models from there and start working on those. Now, it's not that easy when you have those intraoral scans coming. If they are closed, if there's no holes, like this case, the doctor sent me these scans, it kind of looks weird, the base and all, because the doctor himself closed those holes on those scans. So I could send this to my printer and print them right away. Now, most of the times they are coming like this, all open. So you cannot just grab this file and send it to your printer. You have to work on them. So another great software to do this, at least, is the MetaLink. It comes with the software. It's the software for the Medit scanner. I have the internal scanner, the Medit 500, and that came with it. Most of the people do not know that the software is free, and you can just simply grab an STL file and add a base, and just print your model right from there. If by any reason you get two scans aligned, you can also add some articulation pins and just send it to the printer and print from there. So if you have nothing digital, if you have no equipment at all, know that just with these two free softwares, you can start accepting intraoral scans. Of course, that you will need at least to get a printer to print those models, but you don't need to invest in any software at the beginning if that's what you want, just to start getting started on the digital way. And this is just a little video of how the model builder on that MetaLink works, and it's very basic. So basically, let me lower the volume a little bit. So basically, I scan myself. This is me. I scan myself, and I just add the models into the software. You just select the area that you want to keep in your model, and right away they are aligned. You select the base on the base that you want to add on the models. Creates the bases right away. Because they are in center relation, I just added the pins. And then you can just add the name of the patient to it, and then you're done. So it's less than 5 minutes, and it's something that is very easy to do. And just to get started, you can just get a printer and you start accepting this digital scans. And if something, you just print your models, and then you start working on them just like your analog way, trimming the teeth, and adding setting your teeth and designing, processing your denture as you would do in the articulator. I'm sorry, I need to drink some water. So again, this is the very first case that I received. I got the photos at the time. I didn't even have a proper software to open the STL files, and I freaked out because I had no clue what to do with them. And honestly, I just sent it to my friend. I called my friend, and you have to do this case for me because I don't know how to get started. And along the way, please explain to me what I need to do to start designing visually. So he used 3Shape, and this is the photos that I got from the patient. He started doing the visual design with the photos of the patient. He sends the photos to me. He sends me also the tooth proposal with the overlay with the old teeth, all the reduction that he did. And if you see, we have to be careful with the type of scans that we also receive, because in those anterior teeth, there's barely any space for our flanges. So at this time, what he told me, because I was thinking, how are you going to do, teeth and pink at that region? That's barely impossible. And the best decision at the time was to print everything in one color, just so it'd be a little stronger, and then add some pink around the tissue. So this was my very first printed denture, and this is probably 4 years ago. I was scared to death that this was going to break and it was not going to work out because I was not used to do this type of cases. But the last photos are from the iPhone, so it wasn't that pale and that weight, but it turned out pretty well. I was very happy with how everything turned. The midline is off, yes, but based on everything that I went through, we started designing this case and all the information that I didn't know and I didn't know what to do. I was pretty happy for a temporary like that. But now, because I started designing my own cases, and again, that was 2018, we are in 2022, I learned, my way of designing. And nowadays, I design my cases. I use Exocad But all my cases now, I design the teeth and the base, splint file, and then I just print them and assemble them together. So for that, if you want to get to the digital route, you need to either a printer or a milling machine. I don't have a milling machine. I have a printer. I'm very satisfied. I have the Einstein. Actually, I have two, and that's where I print all my dentures now. In March of this year, I transitioned from acrylic dentures to Flexera, to printed dentures with Flexera, and I'm very happy with the transition and how the material behaves with in my conversions and my dentures. So you print the teeth. Like I said, I do print the split file. I print the teeth, face, the incisal edge down. I want to make sure that the sockets are completely clear. Every time the second question just went up. Every time the question goes up, I cannot do anything on my screen. Here you go. I apologize for that. So I mill the teeth, I print the teeth with the incisal edge down. I want to make sure that the sockets are clear and clean so I can adapt it to the base. On the Einstein, just the teeth, it takes more or less 20-25 minutes to print, and that is for teeth. And sometimes I even add temporaries or tryings that I have to do. It doesn't matter if you print one set or 5 or 6, as long as they all fit, it's pretty much all at the same time. And then I print my base. And one feature that I love about the Einstein is this autopilot feature that orients my base in a way that the supports are not on the intaglio and are not in the sockets. It takes longer to print. So if I'm in a rush, I wouldn't print it this way. But because I have time, at least I can print it the day before the surgery. I love this feature because the supports are very, very easy to remove, and everything is it's the sockets are clean for the teeth, and the intaglio is completely clean as well from supports. Not that it matters much. This is a denture for conversion, so if I print the supports on the intaglio, it doesn't really matter because I'm going to add acrylic anyways. But I like this feature just because it makes everything a lot cleaner to remove the supports and to attach to bond the two pieces together. And then I bond the two pieces together of Flexera. I use the resin, the same resin to bond them together. It's not as, a different bonding, or is the same Flexera, either base or tooth, the Smile Ultra, to bond them together. I cure, and then we use them for the conversions at the end of surgery. And this is that specific case that I designed and how everything turned out at the end. And then don't forget, even on the digital planning, we still need our stent, right? And the great thing about digital is that now, because you design your denture, you already have a file of that denture. So you can simply send it to your printer and you have your stent. So the tedious process that it was before duplicating that denture is not anymore, because you just need to send that file to the printer and just change the tray to a clear resin, and then go from there. But now we also have to do the cuts on the intaglio for our multi-unit selection. Again, bring Mesh Mixer to the rescue. Is free, and again, Mesh Mixer you can do a lot of things with. I just use it for what I need, the basics. And this is something that Jeremy Windinger teach me, how to create the stent in less than 5 minutes again in the software. And basically all you need, you have your denture, you import your denture, you select the area that you want to cut from that denture. Remember, we are just opening the holes on the lingual for the multi-unit selection. You remove on both sides. You have to, the denture doesn't, when you select, doesn't go all the way to the back. And then you are making, from this big hole, you're basically adding small holes. You're reducing that big hole to a small one. So this Mesh Mixer has a feature that if it has small holes into your scan data, it just removes them. And that's what we're trying to do here. We're creating we're bridging these different parts of the denture, making small holes. So in once, when we go to analysis, the software itself right here, it closes all the holes. So literally this video is sped up a little bit, but in less than 5 minutes, you can create your stent. Very easy to do. And then you can just send it to the printer and you don't have to grind all the acrylic in that area once you print the denture. So it's really easy to do. And again, it's free, and it's really good software to do this little things. So now we're going to the conversion. So we went over analog planning, what we all do, getting the impression, setting on disticulator, creating a denture, and the digital. If you want to start getting to those, you can either print your models and then bring it to the analog workflow if you're getting intraoral scans, but you can also start designing your dentures, whatever method you use for the manufacturing. Either you send it out for milling or you print it, is up to you. But once you have those cases, we're scheduling the surgery, we have the patient coming, and for the different types of the conversions, there might be a lot more than just these. These are the ones that I did and that I still do. And they're all done in the same day. So it will be guided surgery. It can be freehand surgery. That's when we don't have those guides, and the doctor still plan the surgery or where the implants go. They still analyze CBCTs and all that, but they don't have a specific guide to just place the implants from. We have the smart system, and we still have the digital conversion that is the most popular now, that the last 2 years, that includes photogrammetry technology. So for the guided surgery, there's different type of guides. It can be stackable guides, it can be pilot guides, it can be full guide. I don't do many of these, probably I did 2 or 3 within my, since I opened my business. But basically everything is designed. You get the CBCT, whoever is designing, it can be a company, it can be a technician. I don't design these cases, so either a doctor or I refer to someone else. We get our design, they design where the implants are going. And the good thing with the digital is that you can just superimpose all the data. You can get your CBCT, you can get the guide from the doctor, the temporary from the patient, and your proposal of the teeth to make sure that everything lines up and you're not going to have any issues down the road when you're at the surgery. And you can confirm the restorative space and all that. And of course, that with guided surgery, the good thing about it is that you know exactly, or you might know depending on the type of guide that they do, but you might know exactly where the holes are for the cylinders. So you can just print your temporary in one piece, and this is one of the cases that I did. I just add some composite on around the teeth for the gums, and once we go for surgery, the guide is placed. They place the implants, the multi-unit abutments, and then your temporary should slide right through the cylinders, making the process a lot faster to accomplish. Now, you have to be aware that if something goes wrong and one implant cannot be placed in that region for some reason, you need to know how to, just restore the patient and open more holes, or pick up a different type of multi-unit for these cases. Now, freehand surgery. These are 95% of my cases. And they, again, like I said, most of Dutch, they do have a plan. They do we do not have the guide for the implant position, but it's still, the entire case is planned by the surgeon. They just freehand the position of the implants. So we go to surgery, extract the teeth. We use our stents for bone reduction to make sure that we have enough restorative space for my finals. And then they place the implants, and we use the stent again for that, to choose the multi-unit abutments. That's why we have that lingual opening. We want to make sure that all the abutments, the screw axis is going to be on the lingual. That's how we correct the orientation of the implants is with the multi-unit abutment. And something that I make sure that I don't like to do conversions of dentures that other lab designed or processed, or even the patient, a patient that comes with the denture. I really like to, I'll try to at least ask the doctor, send me a scan of the denture just to make sure that the teeth related to the bone are, or the gingiva are in the right location, because I don't want to run into an issue down the road that we're picking the multi-unit abutments based on the tooth position. And if that tooth position was not planned properly, we run in issues down the road. So this is just an example for the different multi-unit selections that we have. So if we have the implant placed and you see that the screw axis is already on the lingual of the teeth, that's fine. We don't need to correct the orientation. That position is great. And all we need to do is use a straight abutment, or is the same thing as a 0-degree abutment to place that multi-unit to make sure that we keep the same orientation or the same screw axis for that specific implant. Now, if we have our screw axis coming through the incisal of the teeth, we then need to select the 17 degrees, because we want to make sure that we orient that screw axis to the lingual. Again, we don't want any holes through the teeth or the facial of the teeth. So if you go to the third option, you see that the implant, the screw axis, if it's just from the implant, is coming through the facial of the teeth. So we need to select the 30 degrees to make sure that there's more angle and we're pulling that screw axis to the lingual. So this is very, very important, and is one of the things, the steps that the doctors rely on me the most, at least. And this is something that cannot be overlooked. And it's not so much the type of the conversion or the speed of the conversion, is making sure that everything lines up. So once you go to your final, you don't have any issues with the screw axis. So once we place all our abutments, the freehand surgery, the traditional way of doing the conversion, you basically use blue mousse on your denture to mark the position of those multi-unit abutments or healing caps, depending what time you do them. You place your cylinders and you have to drill holes through the dentures to make sure that your cylinders are passively through the denture. Your denture has to sit in the mouth, not touching or rubbing in any cylinder, giving free space around it, at least 1 millimeter all around, to make sure that when you pick up, you have enough space for the acrylic to go around the cylinder. And then you pick up your case, and then you pick up your denture on the cylinders with any acrylic that you might want, and then you just finish the case as you go. And then once you're done, you have to remember with this type of the traditional conversion, when you make holes through the denture, you have to be very conservative with the holes that you're making. You want to make sure that you keep those holes small enough for the acrylic to flow around the cylinders, but not too wide or too big that is going to damage the integrity of your bridge. You have to be very conservative and go slow, because you might be in a rush and you might start opening wide. And depending on the inclination or the divergency between the cylinders, it might be just easier to just open wide holes, but then you're weakening your temporary because of that. And then you just finish and it's delivered. Now, the smart system. This system is, in my opinion, the best out there for conversions. It was developed in 2019, and I'm just going to overview. And in fact, we have a series of webinars next year that is going to go in detail in every single different system that we're mentioning now. So if you heard about it, you already know how it works. If you haven't, it might be confusing, but it's pretty simple to do. So the difference with this system from the traditional pickup of a traditional conversion is that you do not have those wide holes. You don't have to drill holes through the denture anymore. So if you look at the screw axis, it's very small. It's almost, it was perfectly made for that cylinder, and you didn't have to widen um, anything of your denture for this to happen. So how does this work? So this system is, who was a doctor in North Carolina, Dr. Crawford, he developed this. And you do have to get the system online, and it's smartdentureconversions.com. I do have a promotional code. It's DDC, it's Dora Denture Conversion. It gives you $50, I think, off on the kit. And what I do with this doctor, with my doctors, I never use it. I'll buy the kit myself, and then I show them how it works from the traditional way. And if they want to try it, then they'll reimburse me for the parts, as a technician, or that as a lab that does the conversions. I'm not responsible for the parts, cylinders, and multi-unit buttons, definitely not. I do have some doctors that ask for the parts. I don't. They have to have their stock, but because this is a system that not everyone knows about, I'll buy it myself in advance, and then I bring it to the office, and then I explain how it works, and we go from there. So they have two different kits to get started. You need a bigger kit because it has a bunch of the tools that you will need for the process of the conversion. But basically, how this system works is because of this amazing little screw, and I think they call it separable fastener. And the way that it works is that the head of the screw is made out of teak, and the threads are still made out of the metal. And once you use that screw, under pressure, it will separate. So you will use that screw with a short cylinder that comes with the kit too. And basically, you just treat the denture just like a locator. You use that screw with the cylinders. You seat the denture on top. As long as it's passive on top, that's all you need. You inject acrylic all around the cylinder, and even on top of the screw on your denture, you seat it. And once the acrylic is set, you pop the denture, and that screw just slides from the metal, making the process a lot easier. And then, besides all the other parts in the system, there's this set of drills that it helps you open the screw axis, because you're not making holes in the denture anymore. So this is just an example. We use short screws that comes with the system, short cylinders that came with the system. We use those separable fastener screws. You can see the head of the screw is the big head. And then you do the same process, some blue mousse on your denture. You try to seat it in the pallet. As long if it's rubbing or rocking somewhere, you alleviate, you do again. If it's seated completely free of there's no rocking anywhere, you simply add acrylic all around, and you seat it just like you would do, well, the doctor would do to pick up a locator. And then once it's set, again, you pop the denture, and the screw will separate, and you just need to go to the lab and use those drills to open the screw axis. And for implants, it's really easy to pop the denture. The more implants you have, the more pressure. Let's say they say it's 3 pounds per pressure. So if you have 6, it's going to be a little harder to pop that denture. But if you do all the steps right and there's no undercuts, there's no locking on the denture, and it's really fast to accomplish this process. Just because the difference is you don't have to drill holes through the denture. You don't need to care so much with the divergency of the cylinders, because again, you don't need to make holes. You don't need to pass the denture through those cylinders. All you need is the denture to seat on top of them. And then you have the drills. And the very first one is a very thin one. You go from the bottom of the cylinder. It marks the hole on top. Remember, there's no hole, so we have no clue where the hole, the screw axis is going to be. So we use the tiny one. It's called the pilot drill to mark the holes, the screw axis on top. And then we use the second one just to widen that screw axis into the cylinder. And then the third one is to remove the head of that, the pick of that screw axis that it was inside, protecting the cylinder. So there's no acrylic inside the cylinder at all, because the head of the screw was there protecting the interface from acrylic to go in there. So nowadays, 90% of my cases, I design my own dentures. I design, like I said, in split file. I do teeth separate from the base. I assemble together with Flexera. I use Flexera Smile Ultra. I never tried Flexera Smile. I don't know if there's a difference. I use the Smile Ultra and the Flexera base. I assemble both parts together, and then I use the Smart System for my pickup. This is, most of my cases are done this way, just because once we go to the digital workflow, there's a little bit more equipment that needs to be available, and sometimes there's not. So another thing that we have to consider is the Pontic design. And it's not rare, but I had a couple of doctors asking me to leave my prosthesis high water, not touching the gums at all. I do try not to, and most of them I add acrylic. I want to make sure that the intaglio of my restoration is pressuring the tissue and is conditioning the tissue for the final. We want to make sure that we have a convex intaglio in order to make sure that we don't have hygiene problems and down the road. So we need to try, and of course that depends also the type of suturing and bone reduction that the doctors do. Is not just up to us. And also the implant position, where the implants are and how they treat the tissue. But we need to try at least to make it flat. If there's any undercuts, I try to make it flat, but ideally you want to add a little bit more. You want to condition the tissue. So down the road, when you're ready for the final, you don't have any issues with the hygiene or even losing implants down the road because of that. We don't want any flanges at all, any undercuts at all on the inside. So the digital conversion, it's a lot to process. It's not, you definitely need a course for this. And most of the times, you need to be very good with the digital design before you dig into this, because this happened at the day of the surgery and clock is ticking, and there's not much margin for errors. So if you want to get into this workflow, you do need to be really, really comfortable designing and all the little tricks to make sure that you're not spending extra time with things that you don't know. But basically, for this type of cases, we need design software, be very good, photogrammetry, and a 3D printer, or you need to have at least those services. Now, photogrammetry is expensive, and my doctors, they wouldn't invest in that. Like separate, I work with different offices. They wouldn't invest, like the different offices, they wouldn't invest in this type of technology. I did, just because it just helps me and helps them. It shorts a lot of visits and everything. But I don't use photogrammetry for all my conversions, just because if you want to do that, you need to have at least a 3D printer in the office. Now, if their offices is close to my lab, I can just come to my lab and print in my lab and then deliver the restoration. But I work with offices that are within an hour away from me, and there's no way they're going to wait an hour for the traveling. So this digital workflow, it works more for in-house labs and those doctors that have these cases very often and everything is on their own roof. For me, it was worth it also, not only to offer this option, but also moving to the finals. It makes everyone's lives easier, but it's not an everyday thing, because there's other equipments that they need to have in hand in order to offer this type of workflow. So basically how it works, the photogrammetry technology, there are three services, three companies right now that offer this technology. I have the PIC. It stands for Precise Implant Capture. I love how simply it is. and how easy it makes the alignment and everything else. And basically for this type of cases, you need two things. And one is the implant capture. And again, this photogrammetry, this type of technology and this system, the only thing they do is capturing the passivity of the implants. They do not do anything else. They don't scan the tissue. They don't give you anything else but the implant passivity. So yes, they could, instead of investing the technology, you could just do an impression. Um, oh my goodness, hold on. My computer is running out of battery. How is that happening? This is the first. I'm sorry. Is there any questions?
So far, Dora, we have no questions, but please, if you have any, you can type them in at the bottom of your screen. Thank you.
All right. I'm sorry. Okay. So for the beside, if you don't want to invest in this technology, the doctor could just take an impression of the implants, and then we're talking about time, right? If we're talking about conversions the same day, everything is a process of time. So if it's for finals, you can definitely use impressions and scan markers and just use your normal workflow. But for the same day workflow for the conversion, we definitely need this technology because of the speed. And this is in speed. It actually takes longer to actually place the flags and orient them in the mouth than actually have that data. And this is how quick it is scanning the implant position. And that's it. So it's really quick, very precise. So for the digital conversion, we were for this type of technology, we will need the passivity of the implants that scan. And this is what it gives us. It gives us it brings all our file, all the implants in one. It's not separate that you have to put together. It's one file with all implants attached to each other. And then we will need also the soft tissue registration. We need to superimpose one into the other. Now, this is the surgery. It's a lot easier to just take a quick impression and scan it instead of trying to scan the mouth with the blood and everything. It makes things difficult. And I have the intraoral scanner. Most of my doctors do not have an intraoral scanner, so I cannot scan the patient. I do not trust them in terms of speed and to try to scan the patient with those conditions, with the blood and sutures and all. So it's a lot easier, although this tray is not for a specific case at the end of surgery, but it's a lot easier for them to take a quick impression and then me scanning an impression and then just bring it to my software and merge everything. So these are the two things that you need. You need your soft tissue, and you need your implant capture, and then you need your soft tissue so you can align one on top of the other. And then you bring it to your software and you just superimpose everything and you merge all the data. There's different scan strategies to align this, and that's why I say you need to be really comfortable with designing. And then whatever software whatever system you buy, I'm sure they will give you a proper training for all the strategies that you need to learn how to merge all the data. That's why I don't dig so much into it, because it can be very overwhelming. It was for me at first definitely was. But basically you bring all your data together, and from your denture design, you basically just do what you normally do with a burr. You cut your flanges, you cut your cantilevers, you smooth the intaglio, and then you just send your restoration to the printer, ready to insert. So this is one of the cases that I did. It was my very first one. I have to say, it took me a little longer than expected with the redesign, and we start right with the double arch. But basically, this is how the plan was, more or less. I got the STL files. I got the photo of the patient. I merged everything together on my software. I started designing the teeth. making sure that I have enough restorative space. Also, when I design my dentures, I don't do any reductions at all. I design at least for this type of case, I design my teeth. I For the stent, I want to make sure that there's no two pieces, right? I want to make sure the teeth and the base are in one. I save this file and I send it to the printer for my stent because I want to, although we're doing the digital conversion, my doctor still needs the the stent to make sure that all the multi-unit abutments are coming through the lingual of the teeth. So we print the dentures, we design the dentures, we send it to the printer for the stents, and I still use those same dentures also for implant for the tissue capture down the road to be able to merge everything together after the surgery in my software to do the realignment and redesign of my fixed temporary. Because this is the process. Once I have the tissue scan and I have the tissue scan after suturing and the implant position, I can just come back to my software, delete my tissue. And again, this might be overwhelming, but I'm just giving you the basic points of what to do. So I go back to my software, I delete my tissue, I delete my jaws because they're changed, right? I have a new tissue model because my jaw is not the same anymore. And basically, I just redesign my tissue onto my new, I redesigned my gingiva on my new model and then attach the holes and redesign and then send it to the printer. And in this case, actually, I did a little bit of cutback on the gingiva. This is the Smile Ultra Plus Flexera on the Einstein. This is 25 minutes printing. It's really, really quick. And once it's clean and cured, I add some paint around. It can be composite. It can be coloring. There's a few different materials that you can use depending on the type of design that you do. And then we just went back to the doctor's office and it was inserted in the mouth. And that's how it turned out. So for this type, again, there's different types of conversions. This is definitely the craziest. You do need a lot of design experience. But again, if you can also outsource. There's a lot of designers out there now, and even design services that offer the same day design. So if you have the technology, you can definitely outsource the design, get all the scans, outsource the new scans to that whoever is designing for you, and then you just need to print your bridge and add some paint and polish and make it pretty and then deliver to the doctor. So there's definitely a road to be, there's an open road ahead of you. Either you're doing everything analog and you want to transition slowly, or you want to offer more services, depending on how you are comfortable with what you're comfortable with. You can definitely, there's a lot more options now than there used to be, even like 2 years ago. 2 years ago, it was the very first time that I heard about this digital conversion. And it took me months to understand how it worked. Nowadays, there's a lot more research. There's a lot more data and information available that it's a lot easier to understand how it works so you can take that decision if it's in fact something that you want to do moving forward. And that is all. I hope I didn't speed up the process too much. I have my information here. If anyone wants to reach out to me for any reason, asking for more, specifics from the presentation, feel free to. But that is all.
Dora, thank you so much. We have one more poll question coming up. And I do want to share the results that I have for the previous. So as far as denture conversions and laboratories that are offering this, we have 25% of our attendees saying yes, they do offer, and 75% said no, they aren't. So is there anything that words of encouragement that you want to give our attendees for the 75% that are not yet offering this service?
Yes, get on it because it's not that difficult. I really feel that the planning is the real important focus that you have to uh, the planning is really important because you want to make sure that your tooth position is the right is in the your tooth is in the right place and restorative space. Once you go to the office for the conversion, depending what system you use, it really depends how the doctors see you also. If they know that you're just getting started, they might understand and might help you, go with the process. Now, if it's a doctor that never did one, don't start with those because it can be very frustrating. But it's full arch is high demand. And I would encourage anyone to learn more about it because once you get the comfortable with it, once you learn the basics, it's not difficult. It's just a matter of understanding and thinking ahead and making sure you follow all the steps and all those little details to make sure that you help your doctor and you have a successful case.
Excellent. So the next was pretty surprising for me. We wanted to know if the attendees are milling or printing their dentures and denture teeth. And it seems that 100% of the attendees that participated are printing. So how do you
Oh,
feel about that?
well, you know, it's great. I mean, as long as you trust your materials, and again, it took me a very long time to trust the material and to convert from a acrylic denture to printing because I tried several in the past and it wasn't there. And that fear of trying a new thing, and then having your doctor calling you and say it broke. Why are we doing this? Like, why did you change? It's that's something that you don't want to have. So it took me a lot of research in order to switch to the printing, and I'm happy to see that other people invested in that as well. And if they're 100% printing and successful, that's great because I don't know the future, but all I hear is that printing is evolving like crazy. So it's good to hear. I'm not alone. I'm happy.
That's great. Dora, when you decided to start printing, was it the actual printer or was it the material that you started to research first?
It was the material, and that is something that I say often. Um, every printer can print, right? Is a type of equipment that um, you can use, but you need to look at the resins. If you want to go to if you're printing models, any printer will do, right? But if you are printing dentures or like for this specific cases, you need to pick the right material with the right conditions, the right properties. And when I wanted Flexera. I was in between Flexera and another material, and it took me a while. It took me almost a year to decide. And what I did back then, it was I would follow doctors, I would follow the Facebook groups and like the threads about 3D printing and the resins and who was saying what about the material. It wasn't the printer, it's the material. But once you choose a material, you have to understand that you have to follow the FDA, protocol. So you cannot just grab any resin. I like this resin, and I'm gonna apply it to any printer. You have to use the printer that is going to that resin. So I chose Flexera. I followed for a year a couple of doctors that were using Flexera, and this was Flexera Smile at the time. When I decided to invest in Flexera, it was the Smile Ultra. So I don't even know if there's a difference or not. But with that, I got the Einstein, and I was so happy with the speed and how it works that I ended up getting a second one. So I have two Einsteins, and I print the teeth in one, debate in the other, or everything else, the models, the surgical guides, the stents. So it's about the resin. You have to pick the resin based on the properties and what you think is best for your business, and then whatever printer is associated FDA approved for that type of resin.
I have another question for you, Dora. They want to know if Flexera is the only validated material for the Einstein.
I think so. I think they are coming out with new partnerships, but I believe that well, no, there's the Einstein and there's the E1, I think that like that's the older printer. Um, but yes, I think Flexera is the only one as of right now for the Einstein or the other printer that they used to have before. Um,
The Envision One.
yes, yes.
Perfect. Perfect. Thank you
But
so much.
I do know that they're coming out with new materials and opening, doors to other type of resins. I just don't know if they did it yet, or when and which ones.
Perfect. The next question that we had for a poll, the results are what material, what resin are they using for printing? So 22% said they were using Flexera, 11% said they were using Meyerson's Trusana, and 67% said they are using a different one, another. So there are many materials out there, like you said, need to make sure that you're following, validated workflows, and following the manufacturer's directions, right, Dora? That's like crucial, especially when you're creating these prosthetics.
Yes, correct. You want to make sure that you follow all the steps, and that goes from printing in the right printer to cleaning in alcohol at the right time, not to let it stay in the alcohol for longer than it's supposed to be, curing the right amount of flashes and everything else. It's like my dentures. I print them and then I leave them in there, and then the next day I come back, I bond them, and then I cure them together. There's protocols that you should follow and read the specifics, because you might want to speed up the process somewhere, and with that rush you might be not destroying but reducing the you know the integrity of that specific material, because of those shortcuts that you might take.